then. All right, so that stuff you just went through, go ahead and go forward again, just to kind of let you know who was talking to you. So we're going to talk through a number of different things today. Actually, this is a related slide deck, but this isn't the most recent one I sent you, I don't think. I think this is the one that I used down at Mahaska here. So I don't know if we can get the other one up. Otherwise, about 90% of the slides are the same. So it'd be okay if we need to use this one. Just tell me, and we will go forward.
This is the only one that was sent to me. So if we could use that
perfect. Let's use it and move forward. About 95% of it's the same stuff. So awesome. So just so you know, I do a lot of work in this world, but my heart is with the patients. I practiced in Harlan, so real similar to Guttenberg's situation with Critical Access Hospital and Clinic, and that's that was my world as a medical director for about 15 years. And so as we talk through this stuff, just know that you know, we talk about a lot of other things, but my heart is really with patient care in rural Iowa. That's my background, that's my passion, and so we try and always do everything we can to improve the care that's provided in those settings. So just a little caveat there, so go ahead and advance. All right, so what are some of the things that you're hearing about these days that are driving kind of value-based payment? We'll just run through these quickly. Next slide. So there's lots of things going on out there, right, when it comes to MACRA and that type of stuff. Go ahead and advance it to the next slide. So this is the kind of stuff that policymakers look at and say, man, the graph's just showing that we're lower in quality. This just happens to be percent of people surviving 15 years after an MI, you know, to everybody else in the developed world just about. And as of early 2000s, and this is spread has actually gotten worse, we're more expensive than everybody else. So relatively speaking, we're lower quality and higher cost. We don't get as much value out of our healthcare system as other parts of the world. Next slide. And what we spend on healthcare is crazy, right? We spend more than about twice as much as anybody else in the world. And it's starting to, obviously, if you listen to anything nationally, really affect our economy, right? So if you could do the next slide. So those are the kinds of big picture things that have really affected things. And at the same time, we know that our population is aging, and those baby boomers, this silver tsunami that's coming, is going to significantly impact how Medicare works and how the finances of our country work, as we go from 40 million seniors in 2009 to, you know, over 70 million in 2030, and we're well through that transition process now. You probably see it in your practices. The Medicare portion of our practices is growing by the day, and that's going to continue. So we got to figure out how to do a better job with some of this, and that's really what's led to MACRA and some of the other things that we're going to talk about next. Go ahead and advance. So there's lots of changes that are going on in healthcare delivery, right? You heard Guttenberg talk about PCMH, lots of work around how do we do a better job providing care within PCMH and outside of that, you know, using technology well, leveraging telemedicine, using health coaches, disease registries, chronic disease management, care coordination based in the office instead of just in the hospital, you know, all of those kinds of things. Lots of changes in how we deliver healthcare that are being explored, tested, implemented, and so that's really the healthcare world we live in right now. Go ahead and advance. At the same time, the payment systems are changing, right? So we're not just going to continue to get paid for the patient sees me as a physician, I put a charge on a super bill and turn it in, and that's what I get paid, and the sum of those charges at the end of the day is what our clinic makes and hospital makes, and that's how it goes. You know, a lot more and more we're going to be not only asked to care for populations of patients and do things outside of just the office visit or hospital visit setting, but we're going to start to get paid differently for taking care of populations of patients and doing care that's not face-to-face in the office or in the hospital kind of care, right? So that's where ACOs start to come in, and risk-based contracts. We see that in some of the new codes you're probably using for Medicare, right? The transitional care management and chronic care management codes that start to pay us a little differently. Those are still fee for service, but they're starting to look differently at what we should be doing and pay us differently for that. The heat is really turned up now, though, with MACRA. And so the MACRA and MIPS, go ahead and advance the slide. That one is really a game changer for our system, right? So if you can go ahead and advance the downstream effects of that. Well, our MIPS score from 2017, which is already done, and we'll get that result later this year. That's going to affect what I'm getting paid by Medicare next year in 2019. My score for this year is going to affect it in 2020. And so it really is starting to not just be theoretical and something that might happen, but something that's really going to start to affect how we get paid, how we provide the care we provide, and therefore we have to kind of look at things a little differently. And most of this is driven around the triple aim. So that whole idea of providing better care for individuals, smarter spending, and healthier populations. And really, in that process, there's more more and more talk about the quadruple aim, which adds, if we do that other stuff, but we burn out our nurses and our docs and our clinic folks and everybody that's taking care of people, the people in the healthcare system, the clinicians, we're not going to get the results we want, right? So we really have to be doing those three things with an eye at the same time to how do we do it smartly so that we actually make the experience of those providing care better, not worse, not the deaths by 10,000 clicks in an EHR all over again with other things, right? So next slide, please. So the underlying theme of most of this stuff, right, is pay for value, is value-based payment. So what is value? In this kind of setting, a value is usually some combination of higher quality. So that can be better outcomes, better safety, better patient experience, better service, those kinds of things. So an improvement in quality of the care we provide with a decrease in the cost, right? So you can get more value either keeping quality the same and lowering costs for the same quality, increasing the quality but keeping the costs the same, or ideally what we'd like to do is gradually and continually be working on providing higher quality care across the board, while we also keep an eye on what are things from the cost standpoint that we maybe could do better and lowering that as well. Next slide. So this is what Medicare is thinking. So this is actually a CMS slide. Looks kind of complicated, but basically what it's telling us is on that left-hand side, that's where we're at now. That big orange dot there, that's fee for service. So that's how most of us get paid mostly from Medicare right now is, you turn in a bill for the services that were provided, and that's how we get paid. More and more, we're going to get moved from that category one sort of up the ladder to the right of how that fee for service is now linked for quality. We have to start to provide some quality reporting to CMS. Other alternative payment models, ACOs and other payment models that still pay fee for service, but now have some additional payment added onto it to that category 4, where, man, we start to migrate away completely from fee for service to getting paid for taking care of a group of folks, not just doing a set of tasks or a set of visits, right? You can see CMS and their kind of thought process, they're moving to that future state of there may still be a little bit of fee for service, but more and more and more of that gets tied to quality, gets tied to population care. So all the things that you guys have just been discussing with health coaches and care coordination and improving how you provide care in your practice, that's the solid basis you need to move from the fee for service stuff into those other alternative payment models and moving to that right-hand side of this slide. So you're doing the right work to be set up to do well for this kind of stuff, right? Next slide, please. So if you're a nurse, if you're working in a hospital or a clinic setting, these are the kinds of things. You kind of just look at this word diagram here. This is the stuff we're used to thinking about, right? This stuff feels pretty comfortable. We're used to these kinds of words. This is what we do. This is who we are, that kind of stuff, right? The problem is moving forward as the world changes around us. Let's look at the next slide. This is really more what we're being asked to start to think about. right? So what is value-based payment and risk and change and transformation of healthcare and rethinking things and partnering differently and patient satisfaction? I mean, all these kinds of things, right, start to become more and more important in our daily role of providing healthcare to our patients and our communities. And so this is the stuff we have to increasingly start to think about, and it's not an overall, switch. The stuff on the first slide, that's still just as important, right? We're still providing healthcare and doing all of those things, but we have to start to understand some of these other things and how they relate to how the world's changing around us and how we can function well in a healthcare world that's transforming. So next slide, please. So there's lots of new acronyms out there, and we're going to kind of work through the important ones. Go ahead and advance. That's kind of how you feel, right? That's the alphabet soup. So what does MACRA really stand for? A lot of times, next slide, at least the physicians start to think it's all about making all the clinicians really angry. That is not actually what the acronym stands for. Go ahead and advance. So that's the Medicare Access and CHIP Reauthorization Act. So it's a piece of legislation. Next slide, please. So basically, it was passed in 2015. It kind of took effect, just so you know, it was the most bipartisan piece of legislation we've had in probably a decade or more. So it's not something that was highly politicized. It was just because one party was in power or not. It wasn't part of the ACA. It's a separate piece of legislation. So, when Mr. Trump became president and the repeal and replace and all of that, that's separate. The ACA legislation is separate from this MACRA legislation. So this is moving forward. Out of that legislation then came the acronym QPP. That's the Quality Payment Program. So that's actually how Medicare is implementing the rules of the MACRA legislation. So you can probably forget about MACRA. That was just kind of the piece of law that was passed. What we have to worry about in our practices in hospitals is the Quality Payment Program, because that's actually how CMS is doing making those changes to how they're approaching payment to hospitals and physicians going forward, right? So next slide, please. So what does MACRA do? So basically, it divides all of us and kind of puts you in one of two buckets, right? Either you fall under something called the Merit-Based Incentive Payment System, or MIPS, or something called, you're in what's called an Advanced Alternative Payment Model, and we'll talk through both of those. Most physicians, clinicians, people in Iowa, physicians, providers in Iowa are going to fall under the Merit-Based Incentive Payment System. So we'll start there and probably talk about that one the most. But more and more, there will be opportunities for these advanced alternative payment systems or models. So you ought to at least know what that means when somebody says that. So we'll just briefly touch on that. So next slide, please. So basically, if you've been in a hospital system and you've had to do meaningful use reporting, or you've been in a system that's had to do PQRS or value-based modifier stuff, all of those historic CMS programs are now funneled into one combined program called MIPS. So there now aren't all these separate different things you have to report to. All of those are collected under the MIPS program. Next slide, please. So there are four basic components to MIPS. So basically how you got to look at it is every provider, every physician in the country is going to get a MIPS score. So they're going to get a score from 1 to 100 that's determined by CMS and then sent out to you later this year for 2017 that already happened, right? And then based on that score, it's going to start to affect your payment. And the four buckets, or the four parts of that score, are a portion for quality, a portion for cost, a portion for improvement activities, and a portion for advancing care information. When you see that advancing care information, you can see the tablet there, think meaningful use, because that's where most of the meaningful use stuff landed. So next slide, please. So basically each of those categories gets a weight. So they're not equally important to the final score. This was for 2017, which they called a transition year. So in 2017, 60% of that score was based around quality, They decided none of it was going to be based on cost. We weren't ready to be held accountable for cost yet, so that was scored at 0. Improvement activities, so think about that, that is the quality improvement projects you do in your office, the things you do to change the care that you provide to improve the quality of care for your patients, right? And a lot of the medical home activities fall underneath improvement activities. They also directly affect quality in a positive way, but the actual changes themselves sort of fall under improvement activities. And then the advancing care information is the meaningful use kind of stuff. So next slide, please. So in 2017, that is that first column, like we talked about, 60, 0, 15, and 25% is what each of those categories is weighted. This is just to show you that over the next few years, so for 2018, performance year 2018, so that's right now what we're doing, right? The quality percentage goes down a little bit. So instead of being worth 60% of the score, it's worth 50% of the score, but cost now is worth 10%. We start to be held accountable for the costs that we're incurring through the care we provide to our Medicare patients, right? And then you can see, starting next year in 2019, and for each year after that, it goes down so that quality and cost are equally weighted. So just so you know, again, as Medicare is sort of moving us through that fee-for-service to some other type of payment model, even under MIPS, even if you're not in an ACO or some other payment model, if you're just qualifying under MIPS, you're going to start to more and more be held accountable for cost and quality as well, and improvement activities, and the meaningful use of advancing care information stuff. So all of those start to be part of how they look at us. So next slide, please. So what happened last year in 2017, the score that we get in 2017, then it starts to affect payment, which is what this graph is talking about in 2019. So if you got a really high MIPS score in 2017, you might get 4% more for each patient you see in each Medicare claim you turn in 2019 than you did this year. If, though, you didn't report at all and you got the maximum negative adjustment, you might get 4% less, right? And then likewise, moving forward, the score that we get for this calendar year for 2018 is going to affect our payment in 2020. And that can be anywhere from a 5% bump to a 5% loss. Next year's score affects 2021. So you can see 7% up or down and 9% up or down after that. So CMS is really kind of putting our feet to the fire somewhat about, we've got to figure out how to do this higher quality, lower cost stuff if we are going to do well. And the people that do well are going to get rewarded. And the people that are just kind of struggling and not doing well at this can see a significant decrease in payment for Medicare, because this is really what they call a budget neutral thing. So meaning that CMS is going to use the same pot of money. If some people go up 3-4% or 5-7%, over time, other people are going to go down by that much to keep the total the same. Some combination of others, right? So next slide, please. So you'll have to just kind of flip through. The final score is from 0 to 100. Go ahead and keep going. So each year they're going to set a performance threshold, sort of an average score that you have to reach. If you are at that score, you'll just get the same pay 2 years from now, right? So if you attain that score, if you're above that score, you'll get a positive adjustment, that 0 to 4% we just looked at. If you're below that threshold score, then you'll get a negative adjustment here. It's somewhere between 0 and negative 4%. Okay, so go ahead and advance. They also say that there's going to be a threshold of 25% of whatever that performance threshold is. And if you're below that, you're going to automatically get the negative for the maximum negative adjustment. Okay, so that's kind of the lower 25%. The lower 25% of practices are going to get a negative-4 adjustment, right? Or it's not 25% of practices that are less than 25% of the threshold score. To be clear about that. So not necessarily 25% of practices. All right, next, advance. Then on the top end, they have a category for exceptional performers. So there's also going to be a threshold set that if you do a great job and you score really high in MIPS, that you can get more than that 4% bonus. You might get anywhere up to 10%, depending on how many people reach that threshold, right? All right, so you can kind of see on the right-hand side, this goes from 0 to 100. Go ahead and advance. The performance threshold was set very low. So the bar was set extremely low last year. All you basically had to do was report something, and you would get a score of 3, which was, so 3 out of 100, right? So they recognize this is a big change. People aren't used to this. We don't know how it works, what it means. So they set the bar very, very low in the first year. Okay, so pretty much if you went through any reporting, and you still have through March to get that reporting done, if you haven't done it, right, for 2017, that's where you would be. So if you reported something, you're at least not going to see a negative effect of this, right? Go ahead and advance. That exceptional performance threshold was set at 70 out of 100. So if you did a really good job and got a high MIPS score, you might kind of get some of that bonus dollars. And then you can see for 2018, as we're in now, that performance threshold of 3 was bumped up to 15. So they're starting to turn the heat up a little bit, right, to raise the bar of what we're going to have to achieve to not get a negative adjustment or to get a significantly positive adjustment. Next slide. So that's the MIPS stuff. That's how it affects payment. That's the kind of things we have to start thinking about and keeping on our radar if we're going to be ready to do well and continue to get paid well from Medicare, which for most of us in Iowa is, half of our patient visits are roughly, might be 40% or 50 or 55, just depends on where you're at. But usually that's a pretty significant part of our patients that we care for. So we have to be working on taking better care of them, working on quality, and then also looking at the cost stuff going forward as well. So they also talk about these alternative payment models. So what's that mean? So an alternative payment model is, there's a list here of some things. So think about things like ACOs or other demonstration projects that Medicare is doing. There's one called CPC Plus. There's some bundled payment initiatives. There's a number of different alternative payment models that are going on out there that are all kind of lumped in this alternative payment model bucket from CMS. Next slide. So a lot of people that are in an alternative payment model now are in an ACO like some of the ones I run that are a track 1 ACO, which means there's not any downside risk. If we do a great job, we have the opportunity to get shared savings back from Medicare, in addition to getting paid our normal fee-for-service kind of stuff. But we don't have to take any downside risk, meaning that if we don't do a very good job and we actually spend more money than last year, Medicare is not coming to us looking for a refund check because we didn't do a good job, right? So because of that, we are what's called a MIPS APM. So we're in an alternative payment model. We're in an ACO, but we're not taking any downside risks. So our docs still have to fall under the MIPS category, right? So they still will get a MIPS score and get paid under MIPS. All right, so next slide. We, though, get a little different scoring. So if you're in one of those ACOs, and there may well be some people on the phone that are in an ACO through your system. If you're in a MIPS APM, the quality score is worth 50% instead of 60%. We're not being held accountable for costs because we're already doing that through the ACO, so they're not going to separately put that as part of this score. We automatically get 20% because they say you're in an ACO, so you're doing improvement activities, so we're going to credit you that 20%. By the way, for Guttenberg and other folks that have gone through the PCMH certification process, you will automatically get the 100% of the improvement activity credit under MIPS for being a PCMH, certified or recognized PCMH. So that's a nice bonus and benefit. You don't have to jump through other hoops and report other things. That automatically gets you that improvement activity bonus. Like those of us that are in a track 1 ACO will automatically get some of that, right? And then we have to do the advancing care information just like everybody else. So next slide. So these are the alternative payment models. Some of them then are advanced alternative payment models. So remember back to that first slide, you're either under MIPS or you're in an advanced alternative payment model. And the difference for the advanced alternative payment model is they're taking on some kind of downside risk. They are now responsible to Medicare that if they don't meet the budget that Medicare sets for them, they may have to pay Medicare back some of the cost that was given to them, the dollars that were given to them throughout the year. So that's kind of the downside risk. So next slide, please. So if you are in or know some folks that are in Iowa, pretty much the people that would be in this bucket would be in a next generation model ACO. So there are some next gen ACOs in Iowa. We as a state didn't have the opportunity to be in CPC Plus because Wellmark didn't want to play, and so it has to be kind of a combination of the major private payer and Medicare. So we didn't have the opportunity. Nebraska and some of our surrounding states have some of those CPC Plus practices. But there are and will continue to be more of these advanced alternative payment models going forward. And basically what you need to know is if your organization joins one of those kind of models, then you don't have to worry about MIPS anymore. Then all of your accountability happens through the advanced alternative payment model, and you don't have to worry about reporting and scoring and payment change under MIPS, if that makes sense. Next slide, please. But the good part is if you are in one of those, you are eligible then not for those upside, downside risk kind of stuff like the MIPS people are, but you're eligible for a 5% bonus because you're taking some downside risk and stepping out, and Medicare is going to reward that by giving these folks that qualify a 5% bonus check at the beginning of the year. So they'll look at what your charges were for the year before and give you a healthy check to say you're doing a good job, keep it up, keep working on this higher quality, lower cost stuff. And then going forward, once we get to 2026 and some of this phases out, there'll be a higher fee schedule update that those practices will get. Next slide. So this is just kind of a restating of what we already talked about. Next slide. So again, more perks, the more risk you take, more potential financial reward, but you're taking some downside risk. Next slide. So we've talked some, you've heard some already about medical home. So the care changes we're talking about, health coaching, whether you're truly a medical home or not, you know, the care coordination stuff, where does that fit into all of these changes that are going on, right? So next slide. So medical home was really sort of, you know, an outgrowth of a bunch of prior things that happened in the primary care, pediatrics, and then primary care world with the family physicians. Really led to the kind of PCMH recognition programs that are in place now. And again, some of the fundamentals of that are now being woven into these different payment models. Next slide. Oh, next slide, there you go. So if you're not a PCMH, some of the kind of the key tenets or elements of a PCMH, that these are things that should be on your radar and that you ought to be thinking about, even if you are not or don't go forward with PCMH recognition. These are some of the skill sets that practices need to really do well under MIPS, in an ACO, in whatever kind of healthcare world as it develops here. No matter whether it's strictly PCMH or not, access to care is important. Providing that comprehensive care, doing more care management and coordination of care. Hospitals, you know, a lot of the folks on the phone that are part of a true hospital system, you know, you've been doing that probably when I was in our critical access hospital system. We did a lot of that on the hospital side, you know, with folks that were admitted or in the ER, you know, utilization review, I mean, those kinds of things. More and more, if you have an outpatient portion to your hospital system, you have to start to think about, are we doing that care management, that health coaching, that coordination, and those kinds of things through our clinic, like the model of Guttenberg that we just heard from, right? Patient-centered care, obviously important. Quality measurement improvement, are we used to tracking and following quality? Under that MIPS program, you know, you have to pick some quality measures and report on those quality measures to get that score. And so getting used to that idea of following, measuring, and improving quality is an outpatient clinic setting to make sure that your docs have a good MIPS score so that your system continues to get paid well for the care you're providing. That's the kind of mentality we have to start to think about. We look at practice management. Are we doing things well there? Are we using technology well? So, you know, using EHRs or population management, disease registries or other patient registries, you know, are we using those kinds of technologies well? Next slide. So really, you know, the patient-centered medical home principles and the things we just talked about, those really tie back to MIPS scoring, higher score, higher payment. You know, then when there's more dollars coming in, we can hire more health coaches, we can use technology better, we can pay our people better, recruit better people. I mean, all of those kinds of things sort of tie together, right? Again, for the PCMH recognition, you get credit in that improvement activity score under MIPS. So that's an awesome bonus that you don't have to do extra reporting and extra work to get that portion of the score. ACOs, if you are or join an ACO, whether you do well at that depends completely on, can you do a good job managing quality, improving quality of the care you're providing, managing the costs and starting to understand how that works, and addressing high-risk patients and that. And so those kinds of things, the skills that you learn going through PCMH recognition, or you know, at least putting some of those skill sets in place in your practice, that's exactly what you need to do well in any type of value-based purchasing going forward. So whether you're just doing well under MIPS, or whether as you move up that ladder of maybe a track 1 Medicare ACO, or going forward a more advanced ACO, the skills you do and the things you guys are talking about in your meetings this morning, that's some of the basic foundational work to do well in these kinds of changes that are going on in healthcare right now. Next slide. So a lot of times this is how you might feel right now when we start talking about all this payment stuff and all these huge changes, and now there's MACRA, and now I have to maybe think about an ACO someday, all that kind of stuff. Physicians and nurses and staff and everybody around them start to feel like this sometimes. So don't give in to that. All right, this is actually, if we do this stuff well, this can be good for our practices and our healthcare systems. We just have to educate ourselves and make sure that we're moving forward as we should with this stuff. So next slide. So when you're thinking about all these complex things that are going on in healthcare, just remember, go ahead and advance, that this isn't going to happen overnight, right? The changes we talked about aren't something that we move from what we're used to and how we've always provided care and been paid for providing that care and been measured on the quality of the care we provide. This is a process, right? And just like that, the changes we make to the care we provide and what we do are going to be a process. We're not going to radically be asked to or be able to change overnight, but it's not a one-time event, but we're going to have to continue to gradually improve that over time, right? So next slide. So questions, comments, concerns, what is that? Does that resonate with what you guys are hearing, or do you have any questions that I can answer on MACRA and MIPS and physicians and all that good stuff?
Thank you very much, Don. Do we have anybody on the line that has any questions or comments? Please type them into the chat box. All right. It doesn't look like it. So thank you very much, Dr. Klitgaard. We appreciate your flexibility today. And if we do get any questions, we will be sure to send them on to you.
Perfect. Thank you.
Thank you. All right, everybody. That was our last presentation for the day. I just want to say thank you again to everybody for your patience and for sticking with us through the technical issues today. We greatly appreciate it. All of the presentation slides for today will be posted on Hinnovation, and the presentations will be available at a later date as well as soon as we get them transcribed. If you have any questions or comments or thoughts after today's event, please feel free to reach out to your improvement advisor or myself, and we will be happy to help you or get you in touch with the person that is able to help you with whatever your needs are. So again, thank you everybody for joining us today, and have a wonderful afternoon. Enjoy the weather.